You walk into any modern hospital ward, and there is this profound, almost comforting illusion of control.
Oh,
Like,
absolutely.
everything is bright, it's sterile, it's highly categorized. You look down the hallway and you see those brightly colored signs taped to patient doors, right?
Right. The yellow one for this pathogen, the blue one for that one.
Exactly. Maybe a green one near the end of the hall. And it just projects this absolute certainty, this feeling that the medical world has like completely mastered the physical space and everything invisible within it.
Yeah, it creates the atmosphere of this highly organized fortress. I mean, the underlying message of that laminated piece of paper on the door is that the enemy, the pathogen, has been perfectly contained by our administrative protocols.
But when you actually read the literature, when you dig into this stack of sources on isolation precautions in nursing, like we are today, you realize those tidy little signs are covering up a messy, ongoing battleground.
Messy is definitely the word for it.
Right. We treat these protocols like they descended from a mountain carved in stone, but the reality is this landscape is driven by evolving aerobiology, complex fluid dynamics, and frankly, a whole lot of historical trial and error.
Yeah, we are constantly negotiating with biology. The rules we follow today are really just the current uneasy truce we've struck with microorganisms that are actively trying to bypass our defenses.
So our mission today is to decode that rulebook for you,
Yeah.
to look past the laminate and understand what is actually happening invisibly in the air and on the clinical surfaces around you.
It's a huge topic.
It is. We're zeroing in on the modern CDC and HICPAC framework. That's the Healthcare Infection Control Practices Advisory Committee.
Yeah.
This is the standard two-tiered system taught in every single U.S. nursing program.
Right, and the foundation of that is standard precautions,
Yep.
which applies universally to every single patient encounter.
Which basically means treating all blood and body fluids as inherently infectious.
Exactly. Hand hygiene, safe injection practices, throwing on gloves for fluid contact. You do that whether the patient is there for a routine appendectomy or, a mysterious fever. It is the absolute baseline of clinical practice.
And sitting right on top of that baseline is the second tier, the transmission-based precautions, heavy hitters.
Right. Contact, droplet, and airborne.
Okay, let's unpack this. Because before we can understand the massive debates currently raging about how these rules are applied, we have to look at the mechanical foundation they're built on.
The physics of it all.
Yeah, exactly. We have to answer the physical question, how does this specific pathogen actually cross the space between a patient and a clinician?
Because pathogens aren't magic, even if they sometimes feel like it. They obey the laws of physics.
Right.
They need a physical vehicle to cross that space.
Yeah.
So let's look at contact precautions first. The vehicle here is direct touch, or a contaminated intermediate surface, a fomite.
So like a bed rail.
Exactly. If you're dealing with MRSA or VRE, those bacteria are heavily colonizing the patient's skin, the bed rails, the IV pole. The moment you walk into that environment, your uniform is at risk of becoming the vehicle.
Which dictates the protocol.
Right, donning a gown and gloves before crossing the threshold and keeping dedicated diagnostic equipment inside that specific room.
But, reading through the sources, there's this fascinating exception that completely upends this standard routine, and it involves Clostridioides difficile, C. diff.
Oh, C. diff. It is the ultimate trip-up in clinical practice.
Yeah.
It forces a complete behavioral override of the standard hospital routine.
Right, because everywhere else in the hospital, the gold standard, like the absolute reflex, is the alcohol-based hand sanitizer. You finish an assessment, you pump the phone, you rub your hands, you move on.
It's pure muscle memory.
But alcohol does not denature C. diff spores.
Yeah.
It reminds me of working on a car engine. Imagine your hands are just coated in thick, heavy axle grease. If you pour rubbing alcohol on them, you aren't cleaning anything. You're just smearing the grease around your skin.
Right. It doesn't break it down.
Exactly. The only way to get it off is mechanical friction. You need heavy soap, running water, and vigorous scrubbing to physically pry that grease off your epidermis and wash it down the drain. You can't chemically kill the stools with alcohol. You have to physically evict them.
I love that analogy because it perfectly captures the physical mechanics of the spore. C. diff spores have an incredibly hardy protein coat that evolved specifically to survive harsh chemical environments.
Like the stomach.
Precisely, the acidic human gut. So a splash of ethanol isn't going to breach it. You have to rely on the sheer force of soap and water. It's a vital concept because it breaks that deeply ingrained muscle memory of the healthcare worker.
Now, if a pathogen isn't relying on touch, it might be hitching a ride in a respiratory droplet, Which brings us to the droplet precaution category.
Right. The vehicle here is respiratory fluid expelled during a cough, a sneeze, or even just talking. These droplets are relatively large and heavy.
So gravity is doing a lot of the work.
Exactly.
Yeah.
Because of their mass, gravity is the dominant physical force acting on them. They're pulled down to the floor pretty rapidly, typically falling within a 3 to 6 foot radius of the patient.
That implies a safe zone. Like if you are standing 7 or 8 feet away, gravity has already done the protective work for you.
That's the clinical assumption. The required PPE is a standard surgical mask, donned when coming within that physical radius to block those macroscopic droplets from hitting your mucous membranes.
And notably, you don't need any specialized room ventilation.
No, not at all. The droplets are on the floor. They aren't, lingering in the HVAC system.
The sources list the usual suspects for this category, influenza, pertussis, mumps, rubella. But the standout that really caught my attention is Neisseria meningitis, bacterial meningitis.
Oh, yeah, that is a pathogen that instantly changes the temperature in the emergency department.
Because the timeline is so aggressive, right, it can kill a healthy adult within hours. If a nurse or a physician conducts a close-up assessment without a mask and the lab comes back positive for meningitis, that clinician urgently needs post-exposure prophylactic antibiotics.
It's a massive deal.
It's not a situation where employee health says, monitor yourself for fever, let us know. It's immediate intervention. It really hammers home that these precaution categories aren't just bureaucratic suggestions.
Right.
They map directly onto life or death clinical urgency.
Absolutely. But what happens when the droplet is so small that gravity is no longer the dominant force?
Oh.
That is when we cross into airborne precautions. We are no longer talking about macroscopic fluid hitting the floor. We are talking about microscopic aerosolized particles.
So they don't fall.
No, they float. They ride the thermal plumes and ambient air currents in the room, and they can remain suspended for hours after the source patient has physically left the space.
Wow. So a standard surgical mask is essentially useless against that kind of physics?
It offers virtually no protection. Airborne particles simply flow around the loose edges of a surgical mask or pass straight through the macroscopic pores of the material.
Right.
You need a fit-tested N95 respirator, which uses an electrostatic charge to trap microscopic particles, or a PPR, a powered air-purifying respirator. Furthermore, the environment itself has to be engineered.
The patient has to be in a specific room.
Yes, an airborne infection isolation room, or AIR.
The negative pressure room.
Exactly. The HVAC system actively exhausts more air from the room than it supplies, creating a pressure differential. When you open the door, air from the hallway rushes in.
Preventing the contaminated air inside from drifting out and infecting the rest of the ward.
Right. The system is also required to perform a minimum of 6 to 12 complete air changes per hour, physically scrubbing the room's atmosphere.
What's terrifying is that you need that level of engineering because these pathogens are wildly infectious.
What's fascinating here is just how efficiently some of these airborne viruses exploit the air. Look at measles. It has a basic reproduction number, an R0, of 12 to 18. In an unprotected population, one case generates, on average, over a dozen secondary cases. To put that into perspective, in 1985, the CDC investigated an outbreak in Michigan.
Okay.
A child with measles had an appointment in a pediatrician's exam room. They finished the exam and left the clinic entirely. Sometime later, a second child, completely unrelated to the first, was brought into that exact same, now empty room.
Wait, the room is empty. The source of the infection is just gone.
The patient was gone, but the air itself was still contagious. That second child contracted measles simply by inhaling the lingering suspended aerosols in that enclosed space.
Oh, wow.
It's a chilling demonstration of why airborne rooms require high-velocity air changes before they are considered safe to re-enter.
It is chilling. And looking at this modern framework, contact, droplet, airborne, it feels so mechanically logical. You identify the physical vehicle and you block it. But going through the historical sources, it begs a massive question. If this is just applied physics and biology, how did it take the medical establishment nearly 150 years to agree on it?
Well, the delay was driven by a powerful combination of unseen biology and deep professional stubbornness.
Stubbornness?
Oh, yeah. If we look back to the mid-19th century, we see the very first crude attempts at infection control. During the Crimean War in the 1850s, Florence Nightingale didn't actually understand germ theory. She believed in the miasma theory that diseases were caused by bad air.
Right, the classic bad air theory.
But her intuitive response was to aggressively improve ward ventilation and physically separate patients based on their symptoms. It was primitive, but it was effective source control.
Which was happening almost concurrently with Ignaz Semmelweis in Vienna in like 1847.
The tragic pioneer of hand hygiene. He demonstrated with rigorous data that maternal deaths from puerperal fever plummeted if physicians simply washed their hands in a chlorinated solution between performing autopsies and delivering babies.
But the medical establishment didn't just ignore his data. They actively destroyed his career over it.
They were deeply insulted. The prevailing mindset was that a gentleman's hands could not possibly transmit disease.
Wow.
The idea that the doctors themselves were the vectors of death was professionally abhorrent. Semmelweis was mocked, sidelined, and eventually died in an asylum.
That is so sad.
It is a stark reminder that solid infection control data often loses out to professional ego and established dogma.
It really does. And, it took until 1970 for the CDC to publish its first formal hospital isolation guideline. They essentially created a menu of precaution bundles. You had strict isolation or respiratory isolation, and nurses would just select the bundle that matched the patient's diagnosis.
Yeah, that was the model for a while.
But that entire paradigm slammed into a brick wall in the early 1980s, HIV and AIDS.
HIV completely shattered the existing logic of isolation. For decades, the philosophy had been identify the sick patient, diagnose them, and isolate them. But HIV presented a terrifying new reality. You had a deadly pathogen where patients could remain asymptomatic and undiagnosed for years. You simply didn't know who was infected.
So because they didn't know who was actually infected with HIV, they had to flip the whole philosophy from isolate the known sick patient to assume every single person is a risk.
Precisely why the CDC introduced universal precautions in 1985, formalized heavily in 1987. Healthcare workers were contracting HIV through accidental needle sticks and blood exposures. Universal precautions established the radical new baseline that all blood and certain body fluids must be treated as highly infectious, always.
But the sources highlight that this didn't entirely solve the problem on the floor.
No, it didn't.
Because at the exact same time, you had infectious disease experts like Patricia Lynch pushing back. She proposed a rival system called body substance isolation, or BSI, arguing that focusing only on blood was dangerously narrow.
Right.
BSI demanded protection against all moist body substances, feces, urine, sputum, from every patient.
Imagine being a charge nurse in the late 1980s or early 90s. You have two competing, fundamentally different sets of protocols being published and debated simultaneously.
That sounds awful.
One focuses strictly on bloodborne pathogens. The other requires gloves for touching absolutely any body fluid. It created massive confusion and compliance failures on the floor.
That sounds like an administrative nightmare. So how did we finally get to the system we use today?
In 1996, Julia S. Garner, leading the CDC's HICPAC, performed a brilliant piece of clinical synthesis.
Okay.
She took universal precautions, merged it with the best elements of body substance isolation, and created standard precautions, the universal baseline we discussed earlier.
Ah, okay.
Then she took the old, clunky, disease-specific bundles and streamlined them into Contact, Droplet, and Airborne. She built a cohesive two-tiered architecture that finally made sense.
It's an elegant piece of rulemaking. But as we know, pathogens don't read rule books.
They certainly don't.
The tension in these sources really spikes when we look at what happens when the system breaks down. And it does break down. Usually it's a failure of human execution or a failure of the scientific model itself.
Human error is the most common vulnerability. A tragic and highly publicized example was the Dallas Ebola cluster in 2014.
Oh, right, I remember that.
Thomas Eric Duncan was the first person diagnosed with Ebola on U.S. soil. The hospital utilized contact and droplet precautions, escalating their PPE as his condition worsened. Yet two of the intensive care nurses treating him, Nina Pham and Amber Vinson, contracted the virus.
And the subsequent investigations revealed that the precaution category wasn't technically wrong, right? The failure was in the execution, specifically the doffing, the removal of the protective gear.
Yes.
It makes me think of an explosive ordnance disposal technician wearing a bomb suit. The suit works perfectly against the blast, but if the technician decides to unlatch the helmet while the shrapnel is still flying around the room, the suit becomes meaningless.
That's exactly it.
With Ebola, if a nurse exposes even a millimeter of bare skin at the wrist while sliding off a heavily contaminated fluid-resistant gown, the virus finds its window.
Doffing is incredibly perilous. You're dealing with healthcare workers at the end of a grueling 12-hour shift, cognitively depleted, physically sweating inside impermeable gear, and operating under immense psychological stress.
Just a recipe for a slip-up.
The Dallas cases forced the entire industry to realize that having the right PPE is insufficient if your donning and doffing technique isn't flawless and actively monitored by a trained observer.
Right.
But beyond human error, there are terrifying instances where the clinicians do everything perfectly, and the mental model of transmission itself is what fails.
Which brings us to the 2003 SARS outbreak in Hong Kong, specifically the Amoy Gardens apartment complex.
Over 300 residents in a single high-rise complex were infected with SARS-CoV-1, and the epidemiological mapping defied everything we knew about standard respiratory droplet transmission.
Because they weren't coughing on each other in the hallways.
No. The virus was moving vertically through the building's infrastructure.
Wait, I remember reading this in the sources and being completely baffled. How does a respiratory virus travel through a building's infrastructure?
Through the plumbing.
The plumbing.
Yes. The floor drains in the bathrooms utilized U-traps, those curved pipes designed to hold a little bit of water to block sewer gases from coming up.
Okay, sure.
But in many apartments, the floor drains were rarely used, and the water in the traps had evaporated. When a resident who was shedding massive amounts of the virus in their feces used the bathroom exhaust fans created a negative pressure environment.
Oh, no.
It literally sucked aerosolized, virus-laden fecal matter out of the dry plumbing pipes and into the apartments.
Literal airborne feces traveling backward through dry plumbing. I mean, there wasn't a precaution category in the 1996 CDC playbook for that.
Because the medical establishment desperately wants categories to be neat. We want respiratory viruses to exclusively utilize the respiratory droplet vehicle. We do not want them utilizing aerosolized sewage.
Here's where it gets really interesting. Because that deep institutional desire for neat, predictable categories brings us to the biggest scientific brawl in modern epidemiology.
The 5-micron controversy.
Yes, during the COVID-19 pandemic.
It was an absolute seismic shift in infection control. It forced a global reckoning regarding how we define the very air we breathe.
For decades, the rigid textbook definition separating a droplet from an airborne particle was based on a strict measurement, 5 microns.
Right.
The dogma stated that if a respiratory emission was larger than 5 microns, it was heavy, and it would fall to the floor within 6 feet. If it was smaller than 5 microns, it was an aerosol, and it would float.
And relying on that rigid metric, in early 2020, the WHO and the CDC confidently classified SARS-CoV-2 as a droplet-spread pathogen.
I remember.
The public health messaging was entirely built on this. Stay 6 feet away, wear a standard surgical mask, wash your hands, and you are protected.
While N95 respirators were fiercely rationed.
Exactly, restricted only for specific aerosol-generating procedures like intubating a patient.
I always assumed that 5-micron rule was the result of some massive, definitive clinical trial. But aerosol scientists, experts like Lindsay Marr at Virginia Tech and Jose Luis Jimenez at the University of Colorado began looking at this and essentially said, this is fundamentally bad physics.
They did a deep historical dive and realized the 5-micron rule wasn't based on modern fluid dynamics. It was a bureaucratic misinterpretation of tuberculosis research from the 1930s.
The 1930s?
Yes. Marr and her colleagues argued forcefully that human beings do not emit perfectly uniform 5-micron droplets. When we speak, when we cough, when we sing, we emit a massive, continuous spectrum of particle sizes.
Right.
And the physics dictate that in poorly ventilated indoor spaces, even particles much larger than 5 microns can dehydrate in the air, shrink, and travel much further than 6 feet.
And the undeniable tragic proof of this bad physics was the Skagit Valley chorale rehearsal in Washington State in March 2020.
The super-spreading event that irreparably broke the droplet model.
You had roughly 60 people gathered in a room for a 2.5-hour choir practice. They were aware of the virus. They actively tried to maintain distance, staying more than 6 feet apart.
Right, following the rules?
Following the rules. There was only one symptomatic person in the room. And out of those 60 people, 52 were infected.
You cannot mathematically or physically explain 52 infections in a room of that square footage using a 6-foot droplet model. It is impossible.
Just doesn't work.
The virus was not falling to the floor. It was accumulating in the air as fine aerosols, drifting across the room like cigarette smoke. The sheer force of the epidemiological math proved the aerosol scientists right.
And it took months of fierce debate, but eventually, by mid-2021, the CDC and the WHO had to bend to the physics. They revised their guidance, conceding that inhalation of fine aerosols was a primary route of transmission.
The medical establishment had to publicly renegotiate its own foundational science in real time.
Yeah.
If we connect this to the bigger picture, it illustrates exactly why a deep understanding of these mechanics is so vital for the clinician and the informed patient. When the underlying science is this messy and subject to revision, misconceptions thrive on the hospital floor.
People cling to simplified rules of thumb that often fail under pressure.
Exactly.
Let's actually clear the air on some of those operational misconceptions right now, because the sources dedicate a lot of ink to how these protocols are misunderstood in practice. Let's start with vocabulary. I hear isolation and quarantine used interchangeably by medical professionals all the time.
The media conflation of those terms during COVID really entrenched that error, but they are clinically distinct.
Okay, how so?
Isolation is for the infected. You isolate a patient who is confirmed sick or symptomatic to keep them away from the healthy population. Quarantine is for the exposed. You restrict the movement of an asymptomatic person who is exposed to a pathogen, waiting to see if they develop the disease.
Ah, okay, that makes sense. Here's a massive point of confusion on the floor regarding room assignments. If a patient is on droplet precautions, they must be in a negative pressure room.
That is a persistent myth, largely driven by the lingering trauma and hypervigilance from the pandemic. Droplet precautions do not require negative pressure.
They don't.
No, a standard private room with normal HVAC ventilation is perfectly adequate because those heavy droplets are settling out of the air. Reserving negative pressure AIRs is strictly for airborne precautions, where the virus is actively riding the air currents.
Which leads directly to the mask myth. There is a deep psychological reliance on the blue surgical mask to stop anything respiratory.
Well, a standard surgical mask is essentially a splash guard. It's highly effective at stopping large droplets from hitting your nose and mouth, but it does not form a seal against your face.
Right.
If you are dealing with tiny, suspended airborne particles, they will simply follow the air current right through the gaps of your cheeks. If a pathogen is airborne, anything less than a fit-tested N95 is an illusion of safety.
But the pendulum swings the other way too, right? Because of that fear, you see an over-application of airborne precautions. The assumption that any infectious respiratory illness demands an N95 and a negative pressure room.
That better safe than sorry mentality is understandable, but it creates massive operational bottlenecks. Seasonal influenza, for instance, requires only droplet precautions.
Okay.
If a hospital routinely places standard flu patients in airborne rooms, they will rapidly exhaust their specialized infrastructure. When a patient with active pulmonary tuberculosis or measles arrives, the resources they genuinely need to survive won't be available.
Let's look at one final misconception going back to contact precautions. A nurse is rushed, an IV pump is beeping, and they think, I'm just running in to silence the alarm and grab a trach. I'll just throw on some gloves. I don't have 45 seconds to tie a gown.
That shortcut completely neutralizes the precaution. Contact protocols mandate a gown and gloves for a reason. If you lean across a bed to silence that IV pump wearing only gloves, your unprotected scrubs will inevitably brush against the bed rail or the linens. You've now transferred MRSA or VRE to your uniform.
You become the vehicle.
Exactly. You will carry that fomite out into the hallway and introduce it to your next patient.
So what does this all mean? Why did we just spend this entire deep dive obsessing over fluid dynamics, historical U-traps, and the cognitive load of doffing PPE?
It matters because the stakes in modern healthcare are astronomical. Hospital-acquired infections, driven by protocol failures, cost health systems billions and drive the terrifying acceleration of multi-drug-resistant organisms. When a patient acquires VRE or C, diff, because of a broken chain of infection control, it dramatically prolongs their suffering and limits our pharmacological options.
And it extends far beyond the ICU. With the rapid resurgence of measles in under-vaccinated populations globally, a deep mechanical competency in airborne precautions isn't just a niche skill for an infectious disease specialist.
No, not at all.
It is an immediate, highly relevant necessity for every single healthcare worker.
And beyond the clinical mechanics, there's a profound philosophical lesson hidden in these sources. We are conditioned to view medical guidelines as absolute, settled truths.
Right.
But the collapse of the droplet versus airborne paradigm during COVID-19 proved that these categories are merely our best temporary attempts to impose order on a chaotic microscopic reality.
Those brightly colored signs on the hospital doors are essentially just clinical simplifications.
Exactly. This raises an important question, a final thought I'd like to leave you to ponder on your own today.
Okay.
If the strict 5-micron boundary between a droplet and an airborne particle was just a convenient clinical simplification of messy physics, one that spectacularly fell apart when tested by a novel virus. What other rigid life-or-death medical rules are we unquestioningly following today?
Wow.
What other foundational protocols are built on outdated science, just waiting for the next pandemic to expose them?
It fundamentally changes how you look at the physical space of a hospital. Think about that the next time you see a yellow contact precautions sign on a door. The invisible world is significantly messier than we like to admit.
And the rule book is always being rewritten.
Until next time, keep questioning what you think you know.